Well, welcome everyone to the EKG case for the week of April 29th, 2012. We've got a fun case for you this week, and this is a 49-year-old man that presented to the emergency department complaining of chest pain. Now, there's two parts to this EKG interpretation. We're going to talk about the ischemic findings first, then we'll talk about the rhythm. So first, in terms of the ischemic findings, hopefully this is kind of a no-brainer for everybody out there. You're noticing that this patient's having an inferior wall STEMI. So no big surprise there. There's ST segment elevation in the inferior leads. It already looks like the patient's starting to develop some Q waves out there in some of the inferior leads, maybe a little hint in lead 2 and AVF, but lead 3 clearly already starting to Q out. So it's probably the first few hours of this infarction. Now there's a couple of important points to be made. Remember that inferior wall infarctions can extend to two other parts of the heart. Inferior, probably about a third of inferior wall infarctions will extend to the posterior part of the heart, and about a third of inferior infarctions will extend to the right ventricle. And in previous weeks or months, we've talked about both of these types of infarctions. If you want to know whether it's extending to the right ventricle, the simplest thing to do is to do right-sided leads. We're not going to go into that right now. If you want to know whether the inferior infarction is extending to the posterior part of the heart, the simplest thing to do is to do a couple of posterior leads. However, in this particular case, you can probably diagnose posterior extension of the inferior infarction even without the use of posterior leads, because this patient has a very classic finding for posterior extension. Specifically, there's tall R waves in V1, V2, V3. There's upright T waves in those leads, and also there's ST segment depression, maybe just a hint, if any, in V1, but definitely in V2 and in V3. And that's your classic triad for posterior infarction. Now, just a quick word. Sometimes people look at this and say, well, how do you call that a tall R wave in V1 when it's only a couple of millimeters? Well, the use of the term tall for tall R wave is very relative. Even though the R wave here is only a couple of millimeters, it's just about the same size as the S wave. And in my mind, tall R wave is defined as an R wave which is approximately the same size or bigger than the S wave. So when the R wave is about the same size as the S wave or bigger, then that's considered a tall R wave, even if the overall magnitude of the entire QRS complex is still pretty small. So anyway, this person has an acute inferior, posterior, and possibly a right ventricular MI as well. And if you wanted to confirm right-sided MI, then you just do those right-sided leads. Okay, enough about the ischemia and infarction. What I next want to focus on a little bit more is the rhythm, because the physicians taking care of this patient and the EKG machine, and even to some extent the initial admitting doctors, got the rhythm wrong. And I think it's because they relied on the machine. Now, I don't know how they interpret, or rather how machines interpret rhythms, but my guess here is that this EKG machine called this sinus rhythm, just plain old sinus rhythm, or sinus bradycardia actually, with a rate of in the 50s or so, because the machine was looking at these blips, and that is the formal word, blips, right there in V2, and probably just assumed that those are sinus P waves, and this is just the normal sinus rhythm, or sinus bradycardia, no big deal. But, you know, I would say that you should be really skeptical about calling those P waves. The reason I say you've got to be skeptical about calling those P waves, there's a few reasons. First of all, these so-called P waves have a different morphology. If they're coming from the sinus node, they should pretty much have the very similar morphology. Secondly, the PR interval is a little bit different between these two complexes. And then third, I'd pose a question to you, where's the rest of the P waves? Is this little blip right there a P wave? Is that blip a P wave? And if they are, then these should map out, and they don't map out. So you really have to question whether these are P waves, because, you know, it doesn't make sense to call these P waves at all. Instead, and then, you know, I got to tell you the other reason that you question whether those are really P waves is you think about what the money leads are. The money leads are lead V1 and lead 2 for picking up P waves. If you ever want to know whether there's P waves, the first things that you look at are lead V1 and lead 2. V1's not much help here. I don't really see any good P waves in there. But when you look at the lead 2 rhythm strip, right, you got a whole rhythm strip down there to take a look at. There's some stuff going on. Stuff is another technical term here. Stuff going on, which makes you wonder that maybe there are some P waves after all. I'm looking down there at the rhythm strip and I see something there, and I'm just going to walk all the way across this. Hopefully you won't get bored of me for doing this. Something there and there, maybe there, and then, you know what, if we keep going at that rate, right at the beginning of the T wave, it looks like there's a little something there and there. I don't see anything right there, but that's okay. You know, we can keep on going, maybe something there, and then right at the end of that T wave, there's something there and there and there. And now you might be looking at this and saying, you know, you're crazy. That's just artifact. How can you call those P waves? Well, take a look at the circles that I've just made. Those are kind of regular, aren't they? And whenever you're debating, is this artifact or are these really P waves, the simple way to find out what's going on is to just get your calipers and march them across the rhythm strip. And if those blips map out, then it's not artifact. Those blips are therefore going to be P waves. So I'm going to take these arrows. This is my magic calipers, and I'm going to move this right across that rhythm strip, and you're going to see, now I'm not changing the size of these calipers at all, but you'll notice that the P to P interval stays constant all the way across. Now, I mentioned there's a little blip right there, and then in this T wave, I don't see anything, to be honest with you, but I'll keep on moving it across, and then there's the P wave that picks up again. And so when you move these calipers all the way across, it turns out that there is a steady and normal P to P interval that goes all the way across, and therefore you have to assume that these are in fact P waves. All right, so you've got P wave activity, you've got atrial activity in there after all. Okay, now remember last week I mentioned whenever you are interpreting a rhythm, there's 3 steps to the rhythm interpretation. First step, what's the first step, what's the atrium doing? Second step, what's the ventricle doing? And then third step, is there some kind of relationship between the two? So let's take them one step at a time. First step, what's the atrium doing? Well, we've already established that the atrial, and I'm going to put an A there, there is atrial activity going on, right? And the atrium is beating in the 90s or so. We'll just say that there's an atrial rate that's going in the 90s. And remember how we defined sinus node activity? It's got to be upright in all of the limb leads except inverted in lead AVR. Now you don't see atrial beats in all of these leads well, but you know it's upright in 1 and 2 and upright in AVL and inverted in AVR. So you know what, let's just give it the benefit of the doubt and say that this is probably sinus node activity. So first part of the interpretation of the rhythm is this is sinus rhythm with a sinus rate going in the 90s. All right. Next step, what's the ventricle doing? Well, the ventricle is beating in the 50s, and these are narrow QRS complexes. Therefore, it's not a ventricular rhythm. It is either an atrial rhythm that's being conducted, or it is a junctional rhythm, right? Because atrial rhythms and junctional rhythms are narrow. So this is some type of supraventricular rhythm, meaning either atrial or junction. Supraventricular rhythm, it's narrow complex, and the rate's going in the 50s. So we're happy with that. 50 is just a tad bit slow, but not so slow that we need to do anything emergently for that. So we know what the atrium's doing, we know what the ventricle's doing. Now you need to ask the third and final question. The most important question is there a relationship between the atrium and the ventricle? Are they talking to each other? How do you know if they're talking to each other? How do you know if they're communicating? Very simple. The answer lies in the PR segment. If you ever want to know whether the atrium and the ventricle are talking to each other and communicating and are associated with each other, you simply need to look at the PR segments. So let me circle all of your PR segments in here. Well, I think there's a PR segment. That's pretty darn long. And then that's a pretty normal looking one. There's no PR, practically no PR there. And then a really long one. And then kind of a longish one, and then it looks like it's getting a little bit shorter, and then a really short one there, and then a really long one there. So you get the sense that the PR segments are changing And unlike Mobitz 1, they're not slowly lengthening. There's no good pattern to it. They're changing randomly. And whenever the PR segment is changing randomly, what it means is that you have a complete heart block, a third-degree AV block. So let's go back to the beginning of the rhythm. What's the atrium doing? Sinus rhythm right in the 90s. There's a complete heart block. And what's the ventricle doing? Well, if there's a complete heart block, these QRS complexes are not being conducted from the atrium. It must therefore be a junctional escape rhythm, right? And junctional escape rhythm, you know, this rate in the 50s is very typical for a junctional escape rhythm. So the formal interpretation of this EKG is sinus rhythm with the rate in the 90s, complete heart block, junctional escape rhythm with the ventricular response in the 50s, and there's an acute inferior, probably posterior, and possibly right ventricular myocardial infarction. All right, and when the final interpretation was actually correctly made on this patient, the patient was up in the cath lab, they made the proper interpretation, and after the cath, the patient continued to have a complete heart block, and so the patient ended up getting a pacemaker. And that, you know, fortunately this patient did go up to the cath lab because of the inferior MI, but had it not been for the inferior MI, this complete heart block could have been missed because people were relying on the computer, and that dumb computer was looking at the wrong things and calling this just, the computer was saying, this is just a normal sinus bradycardia with the rate in the 50s, don't worry about it. But we know better. You've got to really scrutinize all of the leads, especially your money leads V1 and 2, when you really want to know what the atrium is doing. And when you do that, you realize that this is a third-degree heart block, not just some benign rhythm. Well, so hopefully that was helpful, and you got something out of that. I look forward to talking to you next week. Email me if you have any questions. Okay, bye for now.